Thank you very much. Let me have the privilege of penultimate speaker, right? Followed by Dr. Anup Saraya. Right, then the one which they wanted me to speak is about the ammonia and the you can see that there are two words which have been used, which is very common and then it's been used for quite a long time in the sarcopenia. Myostatosis is the one which has been recently has been coined. And let's see the relationship between these two vis-a-vis to the ammonia. So some people use the word muscle disorder. Myostatosis is basically just like your hepatic statosis, is accumulation of fat inside the infiltration, fatty infiltration of the muscle. Sarcopenia is an anatomical and is the reduction of the mass. But nowadays, previously it used to be thought only the mass, but a function also has been added, and sarcopenia is equal to the lowered mass and lowered function both put together. Right? How do we define the myostatosis? It's defined as a fat deposition into the muscle and characterized as the intramuscular adipose tissue, as the fat beneath the deep fascia, and intramuscular adipose tissue, and the intramyocellular lipids. That means that it infiltrates into the in between the muscle fibers and also inside os. And therefore, it does naturally when something is interfering with the contractile mechanism, if the fat is there, it will be less responsive to heat. What is the relationship between both of these? Sarcopenia and myostatosis often coexist in cirrhotic patients, but myostatosis is considered a distinct entity that can be observed even in the absence of a sarcopenia. We'll go a little bit later about this. Right, then normally the CT is done for both of these, but previously CT was only, they were only looking at the sarcopenia, that is what is the size of the liver. But here you can see that just concentrate, this is myostatosis is expressed in household units with the density, whereas sarcopenia is expressed in the area divided by relevant to the height of the person. These two expressions you have to remember. And then in this you can see that the red is here is a normal attenuation as compared to the myostatosis. The red has come down here, this is the normal here. And also the low attenuation muscles here as compared to the blue, and this one have the yellowness have increased here. And that's how the basically, as you can see here, that this is totally red here, whereas you can see the interspersed with the yellow and then other colors. That's all. But what is problem is that we do not have a standardized. There is no standardized. There is still a controversy remains regarding the definition of what is a low rating density because the ranges are different and people are used different. So we do require a standard both for sarcopenia and also myostatosis in our population. Some people have worked on that one. And this is a recent one, this is an AI-based body composition identifies. This is a retrospective study of AI-based abdominal CT images of asymptomatic individuals undergoing the routine colorectal cancer screening. As you can see here, that age is same in both. BMI is also same in the both. But you see the muscle density here everything is red, and here is that red and interspersed with the yellow. That means there is a infiltration myostatosis is there. So what these are asymptomatic individuals. Not only for the liver, even for the people, healthy people also, this is a fact that look at this person lived about 13 years and then this is about 9 years. So not only that, this is even normal persons can have it to some extent myostatosis depending upon the age and then diabetes and then other features. And therefore this is a myostatosis. And then these people use the word myopenia because they have stood only anatomically, because this is not a, they didn't do any function studies in this one. When we use the word sarcopenia, it means that the anatomy and the function both put together. Nowadays, that's very important for us to realize. So then, sarcopenia, there are umpteen number of literature is there across the world, all over, irrespective of the etiology of the liver diseases, that it is associated with everything what is mentioned. Malnutrition, poor survival, pre-transplant, post-transplant complications, infection, HE, poor quality, HCC, and ascites, and recurrent hospital admission. And the ILBS has been doing an excellent work in the nutrition field, and Dr. Jaya is here, and then therefore I cannot afford to miss her publications here. And then this is the one, which is the top one on the left side, is the critically ill cirrhotics, and you can see the implications are almost 50 to 70% of them, and therefore highlighting the importance of that one. They are more prone for the infections, as we have seen already, and chances of death is fourfold. And the one on the right side is the tips, post tips. Again, there has been influence of this myositis, sarcopenia is there. And the one lower bottom on the right side is the one which is in their center, the transplant center, where it means that 50% they had high incidence of post-operative sepsis, complications, longer ICU stay. On the left-hand side is from the Gangaram, where they try to see what is the set the normal for sarcopenia, not for myositis, sarcopenia. They suggested 29.5 and 35, and then mm squares per ml per year as an abstract. Right, then this is one of the our papers recently published in JCH. We looked at the myositis for early detection, and what our people have done, this is regular anthropometry, including the short physical performance battery, which is a combination of the 4 or 5, 3 or 4 tests, and then it's been ranging, and also the CT and the myostatotic parameters as has been shown here, what has been indicated here. What has been found is that, this is of course the etiology here, and on the right hand side is those people who have been diagnosed as sarcopenic by only anthropometry, SPBP, then one group, and other one is that those who have been diagnosed to have by only sarcopenia, that is L3, and those who have had a myostatosis based on the density. All the three have been looked into here, and what has been found out is that SBBP diagnosis as sarcopenia labeling is only about 40%, whereas if you do L3SMI, that is skeletal muscle index, you could find an additional 6% or so. And if you see the myostatosis, again there is a large difference. There are myostatosis was seen found in about many people who with a normal skeletal muscle anatomy. That's important to realize that a normal still does not rule out that there is a muscle disorder in this people. And the same thing has been echoed in another recent paper. You can see here 433 prospective, multicentric, muscle mass attenuation and muscle function both have been seen. What we did not do is a combination. We just excluded all the three. But what these people have analyzed is the combinations also, isolated one and then combined one. And what is this one is then you can see here that on the top is the sarcopenia and then myo, and this is only isolated myo. These are where they did not find any changes. That's a control group, and this is only the sarcopenia. And you can see that the cumulative incidence of a death is highest in sarcopenia and myostatosis together, followed by very small difference, of course, myostatosis next, and only sarcopenia. Actually, there was only very slightly variable changes. So this indicates that it is the fat infiltration is more important than the anatomical reduction of the size of the muscle. That's important, myostatosis. And this is ammonia. How does it? As you know that the ammonia trafficking here. What is important here is that ammonia is taken up by the skeletal muscles, and something goes to the brain, and the other part comes to this one, and therefore it is only a surrogate marker, you can say, about a hepatic encephalopathy in a way. This promotes the skeletal muscle mitochondrial dysfunction, decreases the lipid oxidation and lipid deposition in these muscles. As you can see here that it is the mitochondrial dysfunction, impaired oxidative phosphorylation, limited lipid oxidation is out. That's how it disposes of the fat inside the muscle. And also, suppose if you give fat in these people, the excess of fat again goes to the muscle. That's the reason why we say that the proteins have to be given, not the fats. And again that will perpetuate and the myositis in these people, excess of fat in giving to the people with the cirrhotics. This is of course composite diagram about explaining all the pathogenic mechanisms of the sarcopenia in cirrhotic people. But what is important for us to realize is the myostatin activation. What is myostatin? Myostatin is a cytokine, and the activation is a negative regulator of a muscle protein synthesis which acts through the mTOR signaling. That means more myostatin is not good. Less myostatin is good. That's all. That is the basic thing. And this impaired myocardial function, increased muscle autophagy, and people have looked at this particular one, as you can see here, that even when you exclude hepatocellular carcinoma, the cumulative overall survival is low in people who have got a myostatin levels as compared to the people who have got a low myostatin. And this one thing which you have to be looked into, the dynamics of the myostatin has to be worked out. And you can see here, not only that, you see here after excluding HCC and the entire group, as the years grow by and the survival has decreased. It's not only the cumulative survival keeps on decreasing as so. This indicates the importance of keeping up the nutrition in people with cirrhosis, which goes without saying. This is another little bit older older paper where they have seen individually the sarcopenia and then myositis. Obviously, they have seen that the hepatic encephalopathy is more in those people who have got a myositis and sarcopenia. Right. And this is a recent systematic analysis of a myositis in cirrhotic people. What does it say? This is almost like a summary. Healthy adults can have also been seen. Almost half of the cirrhotic patients have myositis. Our experience also 50 to 70% they have. Myositis is more prevalent in advanced liver disease. There is more steatosis. Again, that's also a known feature. But what is here is the prevalence of the myositis was higher than cirrhotic patients with diabetes than the non-diabetic, and therefore, even in our study, the prevalence is more in a NAFLD related cirrhotics as compared to the viral physiological cirrhotics. And it may be a risk factor for the hepatic encephalopathy. And it also meta-analysis confirmed the association between HE and myositis, and also has been associated with the previous history of the recurrent hepatic encephalopathy. And therefore, the first systematic review analysis that evaluates the prevalence of myositis in patients with cirrhosis, and they have given more or less guidelines about myositis. So what is for us to ponder now? Malnutrition can affect about 80% of patients with the decompensated cirrhosis. Early identification, management of malnutrition is essential, and the tools to assess are anthropometric measures, tools for assessment of the muscle disorders, the sarcopenia and myositis. This is the anatomical aspect. Both should be assessed in the context of a muscle strength by various functional assessment tests, including SPBB, and these are the functional aspect about that. And sarcopenia and myositis can easily be assessed by the simple CT abdomen at L3 vertebral level. And myositis appears to be a better tool to identify early muscle disorder in patients with the cirrhosis and can unmask many CT LTSMI defined non-sarcopenia. That means that when you do the CT, when you say that there is no sarcopenia by the skeletal muscle index, you can still have a myositis in this people. And larger multicentric studies, especially in our population, are required to validate these findings across. Mainly the normal levels are still not very clear. Vis-a-vis the male and then female, and then these are still not standardized. What we are some of the and the role of serum myostatin levels in the diagnosis and following the treatment of the muscle disorders complicating cirrhosis needs to be further looked into. And ammonia uptake and handling of the muscle is a key pathogenic role in causing muscle disorders in cirrhotics. This is obviously a therapeutic consideration which Professor Anup Saraya will follow